Today, we'll be discussing on the pharmacology of asthma. This is the part 1 of the video. Here we'll talk about the introduction to asthma, the pathophysiology which you must know, and the pharmacological basis of therapy. Let's quickly start with the introduction. Bronchial asthma is a clinical condition that is characterized by the following features. 1. Recurrent episode of coughing. 2. Difficulty with breathing. 3. Chest tightness. 4. Wheezing. And 5. Airway hyperactivity. Bronchial asthma is a clinical condition and it is characterized by these things. 1. Recurrent episode of coughing. 2. Difficulty with breathing. 3. Chest tightness. 4. Wheezing. And 5. Hyperactivity of the airway hyperactivity. What does that mean? Now, recurrent episode of cough means the person coughs every time. The person have an episode of cough. Then the person may have difficulty with breathing. Then the person may start to complain that the chest is tight. The person will start to hear some musical sound when the person is breathing, that's wheezing. Then the airway is hyperactive. You who don't have asthma passes through a region where there's dust, just feel a little discomfort. But for somebody who has asthma, the airway is overactive to just that dust that you actually look at something that is normal. You get? So it's very important to know that these asthmatic episodes can actually be triggered by certain things. What are the things that can trigger it? We have dust, that's one. We have cat and dog fur. We have smoke, drugs such as aspirin and beta blockers, emotions, stress, exercise. These are the things that can trigger asthmatic attack. Now, it is important to know that these are not the only triggering factors. There are other factors that can trigger, but these are just the ones I mentioned here, the most important ones. Okay, next, let's move on now. Now talk about the pathophysiology. This is the most important aspect in this first tutorials, the pathophysiology of bronchial asthma. So now when we say pathophysiology of bronchial asthma, first thing you should know is that bronchial asthma is an example of type 1 hypersensitivity reaction. There are different types of hypersensitivity reaction, type 1, 2, 3, 4. Bronchial asthma is an example of what? Of type 1 hypersensitivity reaction. Do you get that point now? Good. Now, since the example of type 1 hypersensitivity reaction, from that word hypersensitivity, it means the airway is excessively sensitive, hypersensitive. So that's the problem with asthma. Okay, let's move on. Now, the next important point you should know is that antibodies is the same thing as immunoglobulin. So know that point now before we continue the pathophysiology. Antibodies and immunoglobulin are the same thing. Do you get? The immunoglobulin that we have is include immunoglobulin G, A, M, E, D. Gamed. Immunoglobulin G, A, M, E, D. IG means immunoglobulin D. IG immunoglobulin G. Those are the immunoglobulin that we have. Now, for type 1 hypersensitivity reaction, the immunoglobulin that is responsible is immunoglobulin E. So remember, immunoglobulin E is responsible for type 1 hypersensitivity reaction. And we've already said that asthma is an example of type 1 hypersensitivity reaction. So it is immunoglobulin E that is responsible for its pathophysiology. Now, how does this happen? When the individual has been exposed to allergen, let's say for example dust or smoke, for temperature extreme like maybe cold weather. When somebody is exposed to allergen like dust, let's be using dust or pollen as an example. The pollen enters into the airway and the body sees that pollen or that dust as something that is very bad, as an allergen, as something that it must fight against. So the body will now synthesize immunoglobulin E. Remember, immunoglobulin is same as antibody, secreting antibody to go and fight this allergen. Do you get now? So immunoglobulin E is then synthesized and then is then released. Once it is synthesized and released, it will go and bind to the allergen as if it wants to kill it and bind to mast cells. Now, these mast cells, remember what are mast cells? Mast cells are cells that have, if this is a cell, let's say this is a cell. they have a special features. Within the cell, we have granules, and each of these granules contain chemicals, contains compounds. These compounds are responsible for allergic reactions. So when they are released, they will like to fight against allergens, fight against things that your body does not want. So this immunoglobulin E, it feels that dust is toxic to the person, to the human's body, and can kill this person to that extent. So it will go and actually attach itself to mast cells. Once it attaches, take note, it attaches itself to a receptor called FC receptor. That's the receptor it attached to the mast cell. So it attached to FC receptor. No, so this mast cell is said to be sensitized. The mast cell is said to be sensitized. You get it sensitized, but it has not released its contents. On the exposure to the allergen, the antigen and antibody complex. This remember, antibody, immunoglobulin is an antibody. So the antigen and antibody complex, they will go and bind more to these mast cells. And once they bind more to mast cells, the mast cells will rupture and release its contents. The granules will release its contents. Those contents that are released from within the mast cell are what we call primary inflammatory mediators. They are the primary mediators. These primary mediators that are released include 1. Histamine, 2. Tryptase, 3. Protease, 4. Leukotriene C4 and leukotriene D4, 5. Prostaglandin. Do you get? They are responsible for the early response. So once antigen binds to, once antigen enter into the airway, the body secretes and synthesize immunoglobulin E. Immunoglobulin E will go bind to mast cells, sensitize it. On the exposure to other allergens, the same allergen on the exposure, it will cause more immunoglobulin and antigen antibody complex to be formed, and they will go and bind more to mast cell. Mast cell is already sensitized, and this mast cell will now rupture and release its contents. The primary content that comes out from mast cells are these ones we mentioned: histamine, tryptase, protease, leukotriene C4 and D4, and prostaglandin. These mediators that are released, what will they do? It is these mediators that will now cause bronchial smooth muscle contraction. The smooth muscles in the bronchi will start to contract. Remember the tracheobronchial tree. The tracheobronchial tree. That tree is actually the bronchi. Okay, let me just show you here. This is the trachea. The trachea divides into the right and left main bronchi. That's not true. We'll be using this diagram as we are going, especially in the part 2. Good. So this is where air normally passes through. It is actually very narrow, very narrow. Now imagine the muscles that are here are now contracting. When these muscles start to contract, the airway will now become more narrower. You get? So to be hard for the person to breathe, that's why they have difficulty with breathing. Okay, that's just one. So smooth muscle contraction, it is these primary mediators that are doing this now. Also, it also helps for vascular leakage, and it increases vascular permeability. What that means? There are blood vessels surrounding these regions. Now, these blood vessels that are surrounding these regions, what happens is that whenever these primary mediators are being released or secreted, blood from these blood vessels, fluid from these blood vessels, the blood vessels will now be weak. You get? They'll be permeable, and then fluid can pass through these blood vessels to enter into the airway. And once there's fluid in this airway, where air is supposed to pass through, it will be hard for air to pass through. Do you get? So after primary mediators have done their work, because they are for early response, secondary mediators, which are responsible for late response, will now be synthesized. They include interleukin 4, interleukin 5, GM-CSF, and other inflammatory cytokines. Now, what is the function of these secondary mediators? The secondary mediators cause sustained bronchoconstriction. The primary mediators cause bronchoconstriction, but secondary causes sustained bronchoconstriction. Then they also cause cellular infiltration. Let me explain this cellular infiltration. Now, there are some cells. One of the problems that people who have asthma have is that there's infiltration of cells that cause inflammation. Now, this is the bronchial airway, the airway that air is supposed to be passing through. Now, imagine this region is now inflamed. This airway here is inflamed, is swollen. Here is swollen. What will happen to the airway now? It will not be narrow. It will be very narrow. And then any little thing can even block the airway. So this is what secondary mediators also do. They cause cellular infiltration, cells that will cause inflammation. Do you get? Cells that will cause inflammation. The cell that they cause to infiltrate the bronchi is what we refer to as the eosinophils. The eosinophils. They are responsible for causing inflammation, late inflammation phase. Okay, that's for chronic inflammation. So there's chronic inflammation. That's one thing you should know. For that's the reason why any little thing the person may have an attack again. Also, there's mucus hypersecretion by these secondary mediators, and also secondary mediators also stimulate B cells to form more immunoglobulin E. It's immunoglobulin E that will go and bind to mast cells, so it will help to form more B cells to form more immunoglobulin E. This is what secondary mediators do. So this is the pathophysiology. You must know the pathophysiology. Under pathophysiology, know that asthma is an example of type 1 hypersensitivity reaction. Know that immunoglobulin E is responsible, and now once there's an allergen, the body actually want to react and produce immunoglobulin E. Immunoglobulin E will bind to mast cells, sensitize it on exposure, or additional binding will cause rupture. Primary mediators will be released. You know the primary mediators, which will cause bronchial constriction of the smooth muscle of the bronchioles, and also vascular leakage and vascular permeability. So there will be increase in fluid within the airway. Next, secondary mediators will also be secreted. With those secondary mediators, once they are secreted, they cause sustained bronchial constriction, they cause cellular infiltration, they cause hypersecretion within the airway, and they also can cause most formation of immunoglobulin E. So since you know this now, we know the problem of somebody that have asthma. Let's now talk about the pharmacological basis of therapy. That's what we want to talk about. Pharmacological basis. What do you want to treat in this individual? The pharmacological basis of therapy. Once you know the problem, you know what to treat. The problem is that there's narrowing of the airway because there's constriction of the smooth, contraction of the smooth muscle. You get mucus hypersecretion. There's mucus fluid filling that mucus plugs actually within the bronchial airway. There's also bronchial edema, fluid within the bronchial. So if you know this, you'll be able to find solution to what now? To the problem. So the last aspect therefore here. Therefore, the treatment will focus on causing dilation of the bronchi. So that bronchodilators to cause dilation of the bronchi. Do you get now? Then we also need to control inflammation, because inflammation is the cause of narrowing of that airway. And once that airway is narrow, any little you can just block it. You get now? So we need to also control inflammation. So watch out for part 2, where we talk about the drugs that are responsible for this. Thank you very much for your time.